Salvetti with us once again. Fernando is going to talk this time about voice and touch controlled medical checklists, some experiments in medical simulations. It's always a pleasure. So we're going to roll Fernando's intro, and then we'll go to Fernando.
Let me start with the voice and touch controlled checklist that are something pretty unique in our experience, because usually checklists that are mnemonics, that are cognitive helps for medical doctors, nurses, paramedic, are something that are attached to a trolley or are within a pocket or more than one pocket, and people usually are expected to read something on paper. And reading paper sometimes is challenging, because if you think medical simulation, or better, if you think the real medical and surgical life, people many times are in need very urgently, very quickly, to perform actions, to save life, to do something very useful, and usually very complicated, challenging, difficult in order to have aligned the entire team. So try to figure out what usually happens within a surgical room, within indoor or outdoor medical theaters, like the one I'm displaying nearby our title, Voice and Touch Control Checklist. In this case, is a checklist called Name, Claim Aim, designed in Boston by the Harvard Center for Medical Simulation. And if you figure out those type of really challenging situations, we can go step by step together in order to have a better understanding about why and how to use checklist and visual mnemonics in a totally innovative way, not printed on paper, not within people's pockets, but displayed on walls or on big videos. Let me go further just to show the other names, because the team that is experimenting in Boston, Massachusetts, the visual checklist is made by Roxanne Garner, by Rebecca Meinhardt, by Barbara Bertagni, and by myself, Fernando. So we are four, plus some other guys that provide their help to allow us to experiment. I'm talking on behalf of all, and I'm sharing some other images. Then I'm expected to share with you a short video, 3.5 minutes, about what we are doing. In this case, we are within a simulated hospital room. It's simulated even if seems to be a real room, because it's from a virtual hospital, a place where the job is performed by simulation. So it's not a real medical or surgical place. We attached to the ceiling a couple of ultra-short projectors. They are part of the real setting. And we are projecting in an interactive manner 2 walls, better, 1 wall and a half, because the other part of the second wall is already occupied by medical tools and devices. Here is a patient simulator. It's plastic, it's purely plastic. Couple of projected walls. We can look at the main wall. On the main wall, there are writings. there are highlights by virtual pens. There are options to take, again electronically, because we are facing, or better, our learners are facing a very complex situation, especially usual in medical simulation. So they are usually facing a patient simulator, a mannequin, that is about to die, and they have to try to save the patient in 2, 3, 4 minutes. On average, the time is really a short time frame, and medical students or medical professional people, as well as nurses or nursing students and paramedic or paramedical students, are in need to cooperate to figure out what is really happening inside the plastic body, inside the mannequin, and try to find very quickly an effective solution. So they have to share a diagnosis. And it's challenging. It's challenging because knowledge varies between and among the people, because the level of performance may vary a lot. There are people very able to perform, let's say, basic life-size operations on the dummies, and other people that they are not. So the team has to divide the work among the most experienced and the less experienced team members, and they have to share and to try to remain on the same page, to share the basic knowledge and the advanced knowledge about what is happening. Mainly with undergraduate students, it's not so easy. It's really challenging. This is a wall for undergraduate students. This is a wall in order to allow undergraduate students to try to figure out if what is happening is a myocardial infarction or something related to atrial fibrillation. Seems for sure to be something related to the heart, some heart conditions, but they do not know. They have to look at the wall, they have to understand which mnemonic could be relevant in order to start intervening on the medical patient, the simulated patient, the dummy, or as we are used to say, the plastic. And this is from the user experience point of view. From the instructional designer point of view, what is happening, or better, what happened before starting the simulation, some weeks or months in advance, was trying to decide which information were and are very relevant to be shared and shown, which information have to mislead people toward something that is the wrong path, because we have usually to balance the level of complexity. So according to the level of the engaged learners, we have to decide how many true info we have to provide and how many false info we have to provide. So we have to suggest the wrong drugs, we have to suggest the wrong medical maneuvers. At the same time, we have to suggest on the same wall the right medical maneuvers and the right drugs. Then people ongoing the simulation have to take their own decisions, have to balance quantities, timing, level of intervention, and so on. The technical side of the medical nursing performance. At the same time, they have to perform organizational behavior in a very effective way. performing an effective organizational behavior means being able to share knowledge as a team, means under time pressure, being able to bring all within the same page, so within sharing the same diagnosis, remaining the same within the same diagnostical page, and performing according to the diagnosis the right medical procedures. Checklists and mnemonics are part of the scene, in my opinion, are really the core of the scene, more than the patient simulator, from an instructional design perspective, because people have to learn sometimes in real time, ongoing the critical situation, what they have to do. Because medicine is a highly complicated science, and not all the needed knowledge may be available within the, let's say, the brain or the operating memory of people. So part of the knowledge has to be figured out from checklists and mnemonics. This is why we are allowing people to work within a simulated medical environment, learning how to very effectively use checklists and mnemonics in real time without being in need to have someone reading a handbook, usually attached to a trolley. Usually this is the trolley where people find attached a handbook with the checklist. In our case, people directly may look at the same checklist altogether, not only a pair of eyes, as usually happens right now within the real medical simulation settings or the real medical practice settings, because all is displayed on a big wall or at least a big surface. Those are existing checklists. It's pretty impossible reading or looking at them. Those are very famous checklists in the US because they are from Stanford Medical School. They are highly appreciated. They are very good if you have printed checklists, if you can open a handbook. But projecting those type of checklists is pretty impossible, reading them. Those are different checklists designed by us. With us, I mean the professional and experts from the Harvard Center for Medical Simulation, as well as the team from LogosNet and Centro Studi Logos, and a couple of professors from the Polytechnic School of Milano, in order to allow a better comprehension, a better reading, a better understanding once they are displayed on the walls. Different experiment, because we are experimenting different layouts. So same checklist, different layout. And this is the real challenge. Communication partners, knowledge visualization strategies. As you can figure out from the checklist I was sharing before with you, is not easy. Having something like visual communication really working well. In our experiments, we are developing more than 12 different layouts, and maybe one or two are really working. Maybe because we are using simulation in order to check if something that we are designing is working. For instance, this is working. This is a checklist designed by the Harvard Center for Medical Simulation called the Name Remain. I was talking about it at the very beginning of my talk today. and now is also embedded within the Massachusetts General Hospital Handbook of Medical Emergencies. Is technically a checklist plus a mnemonic. The mnemonic is split in three: name, claim, aim, with a very short description about how to perform as a team when the team is facing a situation. And strictly technically speaking, this is the checklist. A list of items, flaggable. Also on our wall is flaggable. In order to keep all the team within the same page, in order to be sure all the team is visually aligned. They know where they are. And this is the wall, purely the brick and mortar wall. At this point, if possible, I'm asking David to start the short video so you can figure out something better about what is the meaning of visual checklist.
Uriel, open checklist 1. Uriel, open checklist 1. Uriel, zoom 1. Uriel, zoom immediate. Uriel, zoom diagnose. Uriel, open 1. Uriel, open 2. Uriel, open 3. Uriel, go to pneumothorax event. Uriel, zoom out. Uriel, zoom 3. Uriel, open 3.
Wait.
Uriel, zoom in. Uriel, next. Uriel, next. Uriel, previous. Uriel, previous. Uriel, zoom out. Uriel, open 5. Uriel, zoom out. And so on. Uriel, zoom 2. Uriel, zoom out.
I think it's enough. We had the time to share a lot of different visualizations.
Uriel, zoom out.
Thank you. So in this way, we are sharing what we are used to do with medical checklist. Is knowledge visualization, and is knowledge interaction, vocal and visual interaction with a piece of knowledge that are very relevant and that we are making available in a different and innovative way, both within traditional medical simulation setting and also within very innovative surgical settings, because surgery is really in need of this type of visualization. Thank you for your attention, and I'm here available if there are questions.
Thank you so much. Always great to see the work that you're doing, and I always enjoy it. It's great to have you here. We have a question from the chat. Elizabeth wants to know, do the medical students also use medical dummies in any of the learning? She's seen some immersive environments that have simulations with heart operations. So are there are there dummies as part of the simulations?
Usually, yes, dummies or patient simulators are part of the scenario. For students, are the main part of the scenario. For us, as instructional designer, knowledge is the main part of the scenario, and knowledge is split in between the dummies and the working environment. With a working environment, I mean also the walls with the projected checklist. But for sure, the dummies are part of the scenario.
Okay, so they're spending some time with the dummies, with the things, the mannequins, whatever, and then some on the walls. Let me ask a different kind of question. So that the checklists were really cool and they worked, really nicely. You could, as you saw with voice activation and touch, as you had mentioned. Do you see a role for those checklists in a real environment? In other words, not an e-real environment, but in an actual environment? Would there be a version of that would work during an actual operation that would work seamlessly? Is that something you envision down the line?
A cardiac surgeon from the Veteran Hospital in Boston is already experimenting visual checklist on a wall within a surgical environment for two main reasons. The first is knowledge distribution among all the team members. The second reason is that cardiac surgery many times means a lot of hours within the surgical theater, and a part of the team that is changing, ongoing the operation, ongoing the procedures. So visual checklist could be of help in order to share knowledge also about what already happened when someone from the team was not physically attending and part of the operations. So two main reasons. I'm not a medical expert. I'm only as an educator working with experts in medical education. Their opinion is that the checklist could help in the real world, not only within a simulated setting. Frankly speaking, I do not know. I'm fascinated because it's the first time I'm working with medical checklists, and I assume that they may help because my colleagues are saying this. So, hope so.
Okay. Yeah, I hope so too, and I would think so. And if Hal Christensen is on the chat at the moment, but I think Hal's thinking would be that it would indeed help, and that would be the kind of performance support that would be very, very useful. I think particularly because, I guess hard to understand the setting, but I know that not being a surgeon, I've seen I've seen them on TV, but because it's voice activated, I would think that would help. There might be some things, but you're fairly busy as a surgeon, and you can't take out your cell phone in the middle of surgery and go look something up. But if you have some kind of checklist that's everyone can see and it's on the wall and can be voice activated to move it, that sounds like it would really, really be a good fit, potentially. Another question from Donna. Donna wants to know, will the results be available for review for medical checklists in a real environment? So I guess when this rolls out, will we get to find out about it when this rolls out in a real environment?
We have, for the moment, a couple of papers in order to start sharing the first outputs from our simulations. In my opinion, by the end of 2021, we will be able to try to export in a real environment. For the moment, within a real environment, we are only working with the HoloLens, providing a checklist, mnemonics, and some other info on the lenses of the main surgical operator. In another project in between Turin and Briançon, Italy and France, we never projected on real walls within a surgical theater, but we are going further with our experiments. And I can assume end of 2021, we will be able to share a robust base of data about all the simulations. We will discuss in January 2022 during the International Congress of Medical Simulation. And then we will look for someone willing to experiment in real places. This is at least the roadmap.
Okay. All right. That sounds great. So Donna, definitely be back at ICLW in 2022. Hopefully they'll come back next year as well. It's like 2021 is going to be when the work is done. This is a lot. This is a lot of fun, and it should be really interesting to see. I know how this works in the real world. I would think it would work well in the real world. That it's got you know, kind of all the right things to be a kind of just-in-time performance support that can work in that environment. But it's a fascinating experiment. Other questions that people have about this? I'll look at the chat. If you have anything else in the chat, we talked about medical students. We talked about the future, and I think and Hal. Hal has chimed in with a yes in all capital letters. So Hal very much agrees that performance support is the way to go, as he always does, and looking forward to the use of these checklists in a real environment as well in a simulated environment. So. All right, well, I think we're just about at the time, so we can wrap up. And I know, Fernando, you'll be back to talk about crisis management in the afternoon, and so we've got more to talk about with you. And you know, that the e-rail system is always just fascinating to talk about, and got a lot of participation. So, all right, well, thanks once again, and we'll see you in a couple hours.
Thanking you. See you. Bye bye.
All right, bye bye. All right, thanks so much.